Hey y'all, it's Dylan, and throughout this presentation, I'm going to be talking to y'all about dementia. To begin this presentation, I will start by defining dementia. Dementia is a progressive decline in cognitive ability in one or more areas from a previous baseline level of functioning that is severe enough to interfere with daily activities. There are many different types of dementia, such as senile dementia, Alzheimer's, Parkinson's, and vascular dementia. The most common form of dementia is Alzheimer's. It is estimated that Alzheimer's accounts for about 60 to 80% of all cases. The prevalence of dementia, and specifically Alzheimer's, is on the rise. This may be due to a longer life expectancy, but in 2011, it was estimated that 4.5 million Americans had been diagnosed with Alzheimer's. This number is projected to expand to 13.8 million by the year 2050. When you account all other forms of dementia, it is easy to see the rapid decline. Clinical presentation. One may question how a patient with dementia will present. Unlike most disease processes, the patient may not be the first person to realize there is something wrong. Most often, it is usually the family of the patient that is the first to recognize a change in the patient and brings it to a provider's attention. Dementia usually has an insidious onset. This means that the patient will generally not be able to tell you an exact time of when symptoms first appeared. Dementia affects many different aspects of life, including retaining new information, handling complex tasks, reasoning, spatial ability and orientation, language, and behavior. Diagnostic studies and assessment. After initial presentation of a patient, you may be wondering, how does a clinician diagnose dementia? The diagnosis of dementia can generally be one of exclusion. As with every other medical problem, an interview and detailed history and physical exam are mainstays of diagnosis. Cognitive testing is also very useful in making the diagnosis of dementia. The MMSE, MiniCog, and other cognitive testing are commonly used. A perfect score on the MMSE is a 30, with 23 being widely considered to be within normal limits. The MiniCog is easier to administer for clinicians, but still has a high sensitivity and specificity. Neuroimaging, such as MRI, CT, and PET scans, can be useful in the diagnosis of dementia. Cortical atrophy can be seen with these studies most often and can be trended by clinicians over time to monitor the progression of the diseases. In some cases, lumbar puncture can be useful in determining a specific cause of dementia. For example, a patient with Alzheimer's will typically have a high concentration of tau protein where amyloid will be low. Treatment. After an accurate diagnosis of dementia has been made, a clinician has to treat it. Treatment varies and is dependent upon the type and cause of the dementia. The mainstay of dementia treatment is still widely symptomatic. Cholinesterase inhibitors like donepezil are generally first-line treatment. As symptoms progress, it is a clinical decision to titrate the donepezil to a higher dose or add memantine. Memantine, an N-methyl D-aspartate antagonist, can be added for dual therapy in patients that monotherapy is not producing the appropriate results. As other symptoms besides memory loss start to manifest, other medications can be added to the therapy, like an SSRI for agitation. It is worthy to note, though, that atypical antipsychotics as a class have been known to worsen mortality in patients with dementia and may not be the best choice for treating some of these other manifestations. There is hope for the future with ongoing clinical trials. In Alzheimer's, for example, there have been experimental drugs that have lowered CSF concentrations of tau and amyloid beta proteins, but have not had a significant clinical impact on cognition. Prognosis and prevention. The diagnosis of dementia can be scary for the patient and the family. They may wonder how long their loved one has to live and how they can prevent from getting it. Prognosis for dementia, again, varies depending on the type. Alzheimer's, for example, has a poor prognosis. The life expectancy is generally, on average, 4 to 8 years, but some extensions of up to 20 years have been documented. As far as preventing dementia, many hypotheses have been proposed. Complying with a Mediterranean diet and aerobic exercise, about 40 minutes 3 times a week, are a couple that are thought to help in the prevention of Alzheimer's. These are my references that I used during this presentation. I hope this presentation and brief discussion on dementia has been useful and informative.